I'm very sorry I couldn't join you there in person, but thanks again for the invitation to present. I'll be presenting on behalf of all the authors our paper on residual severe TR after transcatheter mitral valve repair. I have no disclosures. So, we all know that for surgical mitral valve repair, when you have severe concomitant TR, there's an indication to fix the tricuspid valve as well, along with when there's tricuspid annular dilation. But for the transcatheter population, we really neglect the tricuspid valve. And we know that in prior studies, we've seen that in patients with concomitant severe MR and TR, the TR will improve in less than 50% of patients. And in those patients that have mitral transcatheter edge-to-edge repair with severe residual TR, that's associated with worsened clinical outcomes and decreased survival, as with many other tricuspid regurgitation populations. There's been a few and smaller studies looking at risk factors for having improvement in tricuspid regurgitation, and really they've been kind of variable. So the aim of our study was to identify the incidence and predictors of severe residual tricuspid regurgitation after mitral transcatheter edge-to-edge repair. I'll give you two case examples. Patient number one is an 82-year-old with severe functional mitral regurgitation and a defibrillator, also with severe tricuspid regurgitation. Patient number two is a degenerative case of mitral regurgitation with severe MR and no cardiac implantable device. I think the importance of the study is a few. One, obviously, talking about this with our patients before transcatheter repair of the mitral valve is important to discuss, what the prognostic significance is going to be if their tricuspid regurgitation doesn't improve. Two, when we have trials like Triluminate that are out and already, and many other tricuspid transcatheter therapies on the horizon, who should get a simultaneous procedure if these devices are approved, or some sort of staged intervention of the mitral and tricuspid. And number three, with other studies like Repair MR, it's foreseeable that we may be doing, having the option to do MTIR in patients that are less than prohibitive risk for surgery. So which of these patients should we really kind of push towards mitral surgery with concomitant tricuspid repair? Our question really is the clinical and echocardiographic predictors of severe residual TR. And the trial design was from our cohort of a prospective registry from the Northwell Health system. We retrospectively analyzed all the patients that underwent transcatheter edge-to-edge repair, and we included only patients with severe concomitant MR and tricuspid regurgitation using the 5+ tricuspid regurgitation grading scheme. All echoes were reviewed both pre and post at 1 month, and the echocardiographers were all blinded to outcomes. In terms of clinical endpoints, what we really looked up was 1 month follow-up TTE, and we defined successful TR reduction as a reduction in TR by 1+ with also moderate or less TR. In terms of statistical analysis, we looked at both univariate analysis and then a pre-specified multivariate logistic regression analysis. In terms of the results, as with most transcatheter mitral repairs, the age and STS score was elevated. The successful MTIR occurred in about 85% of patients, which is mostly in line with a lot of real-world studies for these therapies. And the majority of patients were 3+ TR, not massive torrential. We saw that there was an improvement in only about 42% of patients, with most of those, the majority having only 1+ reduction of tricuspid regurgitation. There was no change in 45% and actually worsening of tricuspid regurgitation in 13%. On univariate analysis, we divided groups up between successful TR reduction and unsuccessful TR reduction, and age, AFib, presence of an implantable device. None of these were actual predictors of who would have successful TR reduction. Other Other variables we looked at were echocardiographic variables such as LV and RV dimensions, pulmonary hypertension. All these things did not correlate with improvement in tricuspid regurgitation. Obviously, for patients with an unsuccessful MTR, where they had more than moderate mitral regurgitation by the end of the procedure, those patients tended to have less TR reduction as expected. Really, the only finding in terms of echocardiographic variables was a larger RA area among the patients with unsuccessful TR reduction. In terms of the multivariate predictors for tricuspid regurgitation, we looked at SCAI-TV, AFib, functional MR, pulmonary hypertension, tricuspid annular dilation, and RV dysfunction. And none of those were an indication as to if the patient would have a severe residual tricuspid regurgitation. We also looked at grades of MR reduction, and we did find that the greater your MR reduction was, the more likely the tricuspid regurgitation would improve. And that was really the only multivariate predictor that we could find. What are the limitations? There are limitations of this study, obviously variability among TTE readers. And, with tricuspid regurgitation, as with all other TR studies, it's a dynamic process. Volume shifts, pressure can certainly impact the degree of TR that we're looking at the time of echo at 1 month and pre. This was not a long-term follow-up. Typically, what the literature has shown is that tricuspid valve improvement improves after transcatheter edge-to-edge repair, usually before the first month. So that's why we looked at the 1 month follow-up. And obviously, we were not looking at clinical outcomes. We do know that severe residual TR is associated with poor outcomes. I think, the summary of kind of the interesting points in my mind is that, with severe concomitant MR-TR, the TR will remain in severe in about 60% of patients, and that we don't have any preoperative clinical or echo variables that really help us predict which patients will have TR improvement. MR reduction of 3+ obviously helped the residual tricuspid regurgitation, but in all these cases of MitraClip, we're typically don't know how much we're going to achieve, and assuming that we're going to get a 3+ is not always fair in each case. These prior studies that I mentioned before had varying risk factors for who would have severe residual TR. Our study did not find that any of those, including AFib, pulmonary hypertension, the presence of a cardiac implantable device, was actually a factor for residual TR. We did find that on a univariate analysis, and we did not include it for the multivariate for this reason, but we did find that RA dilation was associated with severe residual TR. However, it's unclear if that is because of the chronicity of the tricuspid regurgitation that leads to more RA dilation, or is it something meaning maybe atrial functional TR is less likely to improve. I think, back to our cases, here's the first case, severe functional MR with an AICD. You see after successful MR reduction, we have trace TR. And here's the second case of a functional mitral regurgitation with severe TR. And despite a good result here, we still have severe residual tricuspid regurgitation. The point being, I'm not sure what your predictions were before the presentation, but we don't really have good predictors for who's going to have severe residual TR. And for that reason, I think it highlights the importance that we have some sort of transcatheter therapy established so that we can treat these patients after we finish their mitral valve, and certainly incorporate this sort of information into heart team discussions for the future. So again, I apologize I can't be there, but thank you again for having me. Some great presentations, and I look forward to some comments and questions from our esteemed panel.
So this was a retrospective study. After performing this, are there variables that you would have included that you didn't have? Are there things you're thinking of that, potentially other hemodynamics or anything about the tricuspid valve morphology? Are you giving up now, or is it just that it's so unlikely to improve should it just be repaired at the same time? Like, do you think we should still keep looking, or?
Yeah, I mean, I certainly think, I think that's a great point, is essentially, this was looking at transthoracic echo pre and post, and now with our improved transesophageal echo imaging, and multiplanar reconstructions, figuring out what sort of morphology the valve has. I think that these sort of things need to be factored into future studies, and looking at a good preoperative TEE to understand the tricuspid valve morphology, where the leak is, CIED induced, CIED associated, and those sorts of risk factors. So I think that the question is ongoing, and especially as we move towards having transcatheter tricuspid valve therapies, and possibly even having patients that are less than prohibitive risk. So severe MR, TR in a high risk patient, should we be offering them a MitraClip or Pascal, given that we know that it's less likely to improve? So I think it certainly opens the discussion and doesn't limit it.